Welcome everyone. So now we are starting another topic, and that is endometriosis. Endometriosis is a condition in which endometrial tissue are present outside of the uterine cavity. So as the normal uterine cavity is produced like this, and ovaries are here, and endometrial tissues are present here. But when endometrial tissues are present outside of the uterus, like in fallopian tube or in ovaries, so that condition is known as endometriosis, and it is estrogen dependent condition. Means any kind of disease, any kind of condition in which estrogen is increased, endometriosis can develop. Exact cause is not known, while it has been explained by various theories like Sampson's implant theory, Myers coelomic metaplasia theory, vascular lymphatic spread theory, genetic and impaired immunity theory. These are different theories which suggest the development of endometriosis. So the clinical feature for this condition is cyclic pelvic pain that has classic symptoms of endometriosis, like cyclic non-colicky pain in nature with lower back pain, dyspareunia means endometriosis within pouch of Douglas, and dyschezia pain on defecation. So these are the signs and symptoms. And the nasal deposit with rectal deposit and urinary deposit. Now in nasal deposit, cyclic epistaxis occurs, rectal deposit, rectal bleeding occurs, and cyclic hematuria occurs in urinary tract deposit. So these are different signs and symptoms, and the infertility also occurs in this condition. Exact etiology of infertility is anovulatory, luteolysis, reduced tubal patency, reduced coital frequency due to pain, and anti-sperm antibody with early pregnancy failure because of prostaglandin induced or immune mediated failure of pregnancy occurs. So these are signs and symptoms for endometriosis. Common sites of endometriosis are pouch of Douglas, posterior broad ligament, uterosacral ligament, fallopian tube, sigmoid colon, appendix, and ovaries. These are sites for endometriosis. Now, ovaries are the most common site for the endometriosis. Most commonly, endometriosis occurs in the ovaries, and ovarian endometriosis is known as endometriomas or chocolate cyst. This is demarcating sign that chocolate cysts are also known as endometriomas or ovarian endometriosis. Uncommon sites are lungs, brain, muscle, and eyes. These are uncommon sites, and less likely chances are there for endometriosis to develop in these sites. Diagnosis will be on the basis of history. Bimanual pelvic examination will show thickening nodularity of uterosacral ligament with tenderness in pouch of Douglas, fixed retroverted uterus with rectovaginal nodules, ovarian mass or masses in it. Investigations will be transvaginal ultrasound, MRI, and laparoscopy is gold standard test for endometriosis. Now, the treatment for this condition is medical treatment is endometriosis causes cyclic pain. Any regime that stops menstruation or induces for pseudomenopause should help with the endometriosis related pain. Now, NSAID should be given with combined oral contraceptive. NSAIDs help for dysmenorrhea and cyclic pain with combined oral contraceptive hormonal pills for dysmenorrhea and dyspareunia. They improve non-colicky pain with contraception. Progesterone should be given, and GnRH analog also given. They cause hypogonadotropic hypogonadism, and daily intranasal spray with osteoporosis longer than 6 months due to side effects. Now, donazole is also the treatment for this ovarian suppression, ovarian carcinoma, hirsutism, voice change, and weight gain, and are commonly used in above complication. Surgical treatment will be conservative, fertility preserving treatment. Laparoscopic coagulation ablation, endometriomas are surgical treatment for dyspareunia, painful sexual activity, perisacral neurectomy, and laparoscopic uterine nerve ablation should be done. So these are the diagnosis, and these are the treatment choices for endometriosis. Definitive treatment include hysterectomy with bilateral salpingo-oophorectomy, remove all visible endometriosis deposit, commence hormonal replacement therapy should be given, and in this way treatment of endometriosis can be done. So after endometriosis there is adenomyosis. Adenomyosis is a disease in which is also known as internal endometriosis, in which endometrial glands develop deep within myometrium. Now, it occurs in multiparous women having ectopic endometrium are the hormonal changes which results in bleeding within myometrium. Now, patterns of involvement are diffuse involvement with focal involvement. Diffuse involvement is most common pattern and focal involvement is known as adenomyoma. Symptoms are patient may be asymptomatic or there may be severe secondary dysmenorrhea, painful menstrual cycle, occurs heavy menstrual bleeding and dyspareunia, difficulty or the painful sexual activity. Now this can be differentiated from fibroids because in fibroids painless bleeding occurs, heavy vaginal bleeding, and in adenomyomas there is heavy vaginal bleeding which is painful occurs. So in this way we can differentiate both of these conditions. Diagnosis is on the basis of ultrasound, MRI as the investigation of the choice, early globular uterus without well-defined mass, and endometrial myometrial interference occurs. Histopathology is only definitive test with examination, and adenomyosis shows symmetrical uterine enlargement. Adenomyosis is soft and adenomyosis having tender uterus, tender, soft, and symmetrically enlarged, while in fibroids there is non-tender and asymmetrical enlargement of uterus. So the treatment for this condition is induction of amenorrhea to avoid endometrial bleeding. Now amenorrhea occurs through GnRH analog or long-acting reversible contraception, levodopa and depo-provera. Classical treatment results in recurrence of the symptom, like definitive treatment is hysterectomy. Hysterectomy is definitive treatment. Now, as you can see here, myometrium is involved in which bleeding occurs, and we have to stop that bleeding. And for that, we should give to the patient GnRH analog and levodopa, and finally, hysterectomy is performed for treatment of adenomyosis. So, in this way, we can prevent this condition. Now, the striking similar condition is endometrial polyps or fibroids. These are focal overgrowth in the endometrium, and malignancy is 1% of the cases. Risk factor are obesity, women having BMIs increased, late menopause, hormonal replacement therapy. Tamoxifen is also risk factor for development of endometrial polyp, and presentation will be heavy menstrual bleeding, intermenstrual bleeding, post-menopausal bleeding, lower abdominal pain, and present in 10 to 20% of the women. Diagnosis will be transvaginal ultrasound should be performed. Outpatient hysteroscopy with saline infusion sonography is performed. Treatment for endometrial polyp is polypectomy. Remove the polyp is the treatment of the choice. Now the fibroids are uterine leiomyomas, smooth muscle tumors of myometrium, occurs in 40% of the women, and they are estrogen dependent tumors. Estrogen dependent tumors. Risk factor are the nulliparous women, women who have never given birth to the baby, obese women having BMI is increased, and having female history, a woman having female history of fibroids can develop. African racial origin can also develop fibroids. So as you can see here, pedunculated masses are present in different parts of uterus. These are fibroids, and these are leiomyoma, uterine smooth muscle tumor. Pedunculated masses and intramural and submucosal subserosal presentation. Now types of the fibroids are intramural, submucosal, subserosal, pedunculated, and cervical masses of the fibroids. Clinical presentation are asymptomatic abnormal uterine bleeding and subfertility, recurrent pregnancy loss, urinary frequency from pressure on the bladder occurs, constipation from pressure on the rectum, and no increase in miscarriage is occur, occurs once a pregnancy is established. Sign will be anemia because of heavy menstrual bleeding. Uterus is asymmetrically enlarged with painless sensation, firm and non-tender. Tenderness may be due to because of degeneration, and on vaginal examination, leiomyoma moves with the movement of the cervix. Differential diagnosis will be pregnancy, ovarian tumor, leiomyoma, adenomyosis, or rudimentary horn of uterus. Complication for this condition is male presentation. A fetus can be male presented, obstructed labor can happen, cervical dystocia can occur, interference of the placental separation, postpartum hemorrhage can occur in this condition. Now, general complications are infection, torsion, and degeneration. So, hairline degeneration is most commonly occurring. Red degeneration occurs when fibroids outgrowth its blood supply, and cystic degeneration occurs when center of the fibroids undergo necrosis, and cystic changes occurs inside the fibroid. That is cystic changes. Now, treatment will be on the basis of investigation, and investigations will be transvaginal ultrasound, transabdominal ultrasound, saline injection sonography, and hysteroscopy. And the treatment of choice will be transaminic acid for bleeding, NSAIDs for pain, GnRH analog for prevention of the bleeding, and pre-surgical shrinkage of fibroid, selective progesterone receptor modulator. Surgical treatment will be myomectomy, hysterectomy, uterine artery embolization for shrinkage of the fibroids. So in this way we can treat for fibroids for myomectomy, hysterectomy, and uterine artery embolization. And the another condition is Asherman syndrome. This is a syndrome in which is also known as uterine syncytial or intrauterine adhesions because of excessive curettage as adhesion of the uterus occurs, and that condition is known as Asherman syndrome. Risk factors of urinary infection over vigorous uterine curettage, tuberculosis, and schistosomiasis. These are the risk factors. Presentation will be secondary menstrual irregularity with amenorrhea, loss of menstruation or no menstruation, repeated miscarriage, and subfertility. Now, treatment will be hysteroscopic adenolysis occurs, and in this way we can treat lysis of intrauterine adhesion can be done. Hysteroscopy, self-oophorectomy, and chemotherapy should be done in Asherman syndrome. So these were some diseases which we discussed, and in next video we will discuss next diseases like endometrial carcinoma and cervical carcinoma. Welcome everyone. So the topic which we will be discussing is hypertension during pregnancy or hypertension in pregnancy. So when hypertension occurs in pregnancy, that condition is known as pregnancy induced hypertension. There are multiple causes of hypertension during pregnancy like chronic hypertension, pregnancy induced hypertension, preeclampsia, eclampsia, and HELLP syndrome. So we will discuss one by one that what is preeclampsia, what is eclampsia, what is HELLP syndrome. Chronic hypertension occurs when the blood pressure is greater than 140 by 90 millimeter of mercury, and at the time of pregnancy that condition is known as chronic hypertension. There are multiple causes of chronic hypertension like essential hypertension, collagen vascular disease, coagulation of the aorta. Renal diseases include glomerulonephritis, polycystic kidney disease, diabetic nephropathy, renal artery stenosis. There are endocrine causes as well like pheochromocytoma, Kuhn's disease, hypothyroidism, and hyperthyroidism can create the condition of hypertension during pregnancy. So the complications will be preeclampsia. It is increased blood pressure along with proteinuria and organ damage like kidney damage. Another is placental abruption, premature separation of the placenta, heart failure, and intracranial hemorrhage can also take place. So the fetal complications include placental insufficiency, growth restriction, preterm baby may be preterm before 37 weeks of the gestation, and increased mortality or morbidity of fetus occurs. Investigations: what lab values will be prescribed? Serum creatinine, urea electrolyte, LFT, 24-hour urinary protein level, renal scan, antibodies can complement the studies, and ECG with echocardiography can also be prescribed. So the management options for the hypertension during pregnancy will be uh, serial routine check of the blood pressure with urine protein assessment because analysis of proteinuria can be mandatory to rule out preeclampsia. Antihypertensive drugs are contraindicated during pregnancy, especially ACE inhibitors. ACE inhibitors should not be given in the pregnancy. Angiotensin receptor blockers, atenolol, and diuretics, these should not be given. But if we really want to control the hypertension of the patient, so we can give labetalol and methyl dopa with nifedipine. But labetalol is more effective as compared to both of these, methyl dopa and nifedipine, so labetalol can be prescribed. Mode of the delivery should be awaited and look for vaginal delivery and the superimposed preeclampsia. It is another condition. So in this way we can manage the pregnancy-induced hypertension. Now let us look at the condition that is pregnancy-induced hypertension. Means hypertension. It is also known as gestational hypertension. Hypertension arising first time in the second half of the pregnancy in absence of proteinuria. No proteinuria is present in pregnancy-induced hypertension. If proteinuria is present, then that condition will be preeclampsia, and preeclampsia is hypertension along with proteinuria with and organ damage. So this diagnosis can be laboratory investigation. Blood pressure will be 140 by 90. Management is conservative management, and appropriate laboratory testing should be done in order to rule out preeclampsia. So in this way we can manage pregnancy induced hypertension by conservative management. Now preeclampsia is a condition in which hypertension occurs 140 by 90 along with proteinuria with end organ damage, and resolves completely by 6th week of the pregnancy. Risk factor will be first time pregnancy, multiparous women with previous preeclampsia in during pregnancy, preeclampsia in previous pregnancy greater than 10 years of the lady baby, last baby, and age is greater than 40. Those women who are above the 40 years may prone to develop preeclampsia. BMI is greater than 30. Obese women greater than 35. Booking diastolic pressure is greater than 80. Proteinuria is positive, and pre-existing medical conditions like hypertension, renal disease, diabetic mellitus, and antiphospholipid syndrome. Patient can also give rise to the preeclampsia. So the pathogenesis of this condition is that failure of trophoblastic invasion occurs in preeclampsia, and because of that there is compromise, decreased blood supply to the fetus occurs, uteroplacental ischemia occurs, and baby may become preterm with endothelial damage and diffuse vasospasm of the mother, and that vasospasm leads to ischemic death of the organs. That's why end organ damage occurs. Diuretic should be avoided in this condition because they decrease vascular volume, and it will result into specific organ damages like cardiovascular system damage, hematological changes like coagulopathy, DIC, hemocrit concentration, renal changes, proteinuria, and glomerulonephroendotheliosis can occur. Liver and CNS. In liver, there will be HELP syndrome occurs, and CNS eclampsia can develop. Grand mal epilepsy, grand mal convulsions can develop. So the clinical features of preeclampsia are differential headache, may be asymptomatic, flu-like symptoms can happen, headache, gastric pain, visual disturbance like photopsia, scotoma, blurred vision, and diplopia can occur in the preeclampsia. So the signs and symptoms of this condition will be elevated blood pressure, worsening edema, brisk reflex, ankle clonus, uterus and fetus small for gestational age. Investigations will be urine lysis for depistic test, 24-hour urine collection, and random protein creatine ratio. These are the investigations. Other investigations are the complete blood picture, coagulation profile, renal function test, liver function test, plasma concentration, and ultrasound of the fetal size and amniotic fluid volume must be assessed, and uterine umbilical artery Doppler with CTG. But the complications of the preeclampsia may be eclampsia, in which convulsions are there, HELP syndrome can be there, cerebral hemorrhage, DIC, renal failure, and placental abruption can take place. So in this way, the complications can happen. Maternal death occurs because of DIC or respiratory distress syndrome, renal failure, and cerebral hemorrhage can trigger the dangerous conditions. So this is the preeclampsia, and there are degrees of the preeclampsia: severe, minor, and major type of the preeclampsia. And the management of this condition will be admit the patient, monitor blood pressure 4 times a day, routinely testing for proteinuria, monitor CBC, LFT, and renal function, and blood pressure should be maintained with oral labetalol because this is the only drug safe during pregnancy. There is labetalol, and evidence for the maternal fetal jeopardy must be done along with administration of the IV magnesium sulfate and labetalol. So the magnesium sulfate along with labetalol are the only drug which must be prescribed in the condition of the preeclampsia. Magnesium sulfate because if patient is developing convulsion, so muscle relaxant is the magnesium sulfate. So in this way preeclampsia can be managed, and the other disease which can create problem during pregnancy is eclampsia. In eclampsia, what happens? Grand male conversions occur, and those grand male conversions along with preeclampsia with cerebral hemorrhage is most common cause of the death, and pulmonary edema in are the maternal complication of the eclampsia. So convulsions along with preeclampsia can create dangerous consequences on the mother health, and this condition must be treated earlier. Investigation will be CBC, full blood count, and clotting studies, cross matching liver function test, urea, and electrolyte function test. Management will be called for the help for the senior, maintain airway, breathe, and circulation, primary survey, maintain IV line, antihypertensive drugs like IV labetalol should be given along with magnesium sulfate because it is anticonvulsant, drug of choice, prophylaxis for the seizure, and cerebral vasodilator, and it should be given in IV bolus. With if it is given in overdose, so the treatment for overdose of magnesium sulfate will be 10% calcium gluconate. So this is antidote for magnesium sulfate. In this way, we can manage the patient of eclampsia. And the another condition which can happen in antepartum and pregnancy is HELP syndrome. HELP syndrome is mnemonic which is characterized by hemolysis, elevated liver enzyme, low platelet, is known as HELP syndrome, and this is mnemonic which whose full form is hemolysis, elevated liver enzyme, and low platelet. As a syndrome occurs in patient having signs and symptoms of the epigastric pain, right upper quadrant pain, nausea, vomiting, tenderness in right upper quadrant occur with increased blood pressure, and differential diagnosis are the thrombocytopenic purpura, hemolytic uremic syndrome. So the complication of this disease will be stroke in the patient is the common cause of the death. DIC and placental abruption, separation, early premature separation of the placenta, acute renal failure, and stillbirth can take place. So this disease presents in this way. So how can we manage this condition? For management, prompt delivery should be done, enhance postpartum normalization of the liver enzyme and platelet count with placental growth of the prostaglandin F, and low prostaglandin F level are seen in preeclampsia, and uterine artery Doppler in preeclampsia it must be assessed. So in this way we can manage the HELP syndrome. Now, antepartum hemorrhage. Antepartum hemorrhage is a condition in which bleeding occurs before 37 weeks of the gestation. That is very dangerous consequences, and there are multiple causes of the vaginal bleeding from 20 weeks of the gestation of the delivery of the baby. Now, causes are the placental causes, local causes. Placental causes are the three: placenta previa, placental abruption, and vasa previa. We will discuss what are these. So, the local causes are cervicitis, inflammation of the cervix, cervical carcinoma, vaginal infection, and trauma can trigger antepartum hemorrhage. Now, placenta previa. It is a condition refers to the placenta which is implanted in the lower uterine segment. What happens normally? Placenta is implanted here in the uterus, but in placenta previa, what happens? This is uterus. This is cervix. Placenta is implanted here in the mouth or the neck of the cervix because normally baby delivers from here, but when placenta is implanted here, that blocks the delivery pathway of the baby, and that condition can create problems. And that condition is known as placenta previa, associated with the maternal blood loss. And when blood is lost, mother will develop hypoxia, hypovolumic shock, and multiple problems can arise. Risk factors are the placenta previa, previous placenta previa, previous C-section, multiple gestation, uterine structural anomaly, and assisted conceptions. Classification will be total previa, partial previa, and marginal previa. There are three types of the placenta previa. In total placenta previa, as you can see here, this placenta is implanted in the main entry side and exit side, and that is known as total placenta previa. In partial placenta previa, here placenta is partially covering the neck of cervix, and in marginal placenta previa, only margin is attached here placenta, so that is the marginal placenta previa. These are three types of placenta previa: total, marginal, and central placenta previa. Now, the clinical feature for this condition is the painless vaginal bleeding. This is important demarcation because in order to rule out other causes of the bleeding, in placenta previa, painless vaginal bleeding occurs, no uterine tenderness, and lower lying placenta on ultrasound. So this is demarcation sign, very important sign to memorize in order to differentiate other diseases. Management will be primary survey with airway breathe circulation drugs and send CBC and type of the screening continue fetal and maternal monitoring transabdominal transvaginal ultrasound must be maintained and must be assessed. So, stabilize the patient with hemodynamic support. Rhesus negative women should be given anti-D immunoglobulin and they must be given these immunoglobulins in order to prevent any problem. If a patient is unstable, administered corticosteroid and emergency C-section should be performed help in order to uh, help the delivery in the patient. So the another condition which can create the bleeding condition, that is placental abruption. Abruption means premature separation of the placenta from the normal sited placenta. In this condition, placenta is sited at the normal position, but premature separation occurs before 37 weeks or the 20 weeks of the birth and 20 weeks of the pregnancy, and that condition can create problem for mother as well as for fetus. Blood loss of the both of these occurs and hypovolemic shock can happen. Risk factors are the hypertension and preeclampsia, smoking, abdominal trauma, cocaine, anticoagulant therapy, polyhydramnios. These are risk factors, and classification of this condition is external or revealed abruption, internal or concealed abruption. Now, as you can see in this picture, bleeding occurs here inside and it is externally revealed. That's known as visible bleeding. While in concealed bleeding, bleeding is happening here, but it is not coming out of the cervix, and a mother is not known about bleeding inside. So this condition is known as concealed bleeding. But this the clinical feature of this condition are diagnostic clue are sudden onset painful vaginal bleeding occurs and the uterus is tender and tense, woody, hard, and placental abruption. While in placenta previa, what happened with painless bleeding with non-tender uterus. So these are the diagnostic and differential points between vasa previa and placenta previa. Complication will be maternal complication like hypovolemic shock because of bleeding, Sheehan syndrome, fetal-maternal hemorrhage, and maternal mortality, disseminated intravascular coagulation, hypovolemia, hypotension, DIC, acute tubular necrosis. Fetal complications include perinatal mortality, preterm birth, and fetal growth retardation can happen. So the management of this condition will be vaginal delivery should be done with administration of anti-D immunoglobulin and C-section should be done if fetus is alive. So in this way, we can manage the fetus and the baby as well and the mother and the correction of the coagulopathy, packing of the uterus, administration of the uterotonic agent and ligation of the uterine artery. So this is the treatment modality for the placenta abruption, placental abruption. And the another condition is vasa previa. Vasa previa is rupture of the vessels on the fetal side. When fetal vessels are ruptured, bleeding occurs only in bilobed placenta having accessory lobe. Villamenous insertion of the umbilical cord should be done, and presentation will be rupture of the membrane with fresh, painless vaginal bleeding. Fetal compromise will be there, and bradycardia of the fetus occurs. Management will be immediate C-section, and delay in delivery should be done. Now, as you can see here, the vessels are ruptured and these vessels are bleeding. This blood is from fetal side. That's why fetal hemorrhage occur. Now, those were the causes of postpartum hemorrhage. Now we are starting in. Those were the causes of antepartum hemorrhage. Now we are going to study postpartum hemorrhage. Means bleeding occurs after labor, after delivery of the baby. Excess blood loss, more than 80, more than 500 milliliter within first 24 hours of the delivery. That is known as postpartum hemorrhage. It is of three types: early primary postpartum hemorrhage, secondary late postpartum hemorrhage, and massive obstetric hemorrhage. So the causes of this condition is most common and important cause is uterine atony. Uterus become atonic and bleeding can happen. Are the fetal macrosmia, prolonged labor, oxytocin use, and induction of labor can also trigger postpartum hemorrhage, which is greater than 500 milliliter. So in this way, postpartum hemorrhage occurs, And other causes include retained products of conception of the placenta, placenta previa, placenta accreta, genital tract infection, coagulopathy disorder, and multiple period C-section. So these are the conditions and causes. And signs symptoms include hypovolemic shock, anxiety, thirst, cold, dizziness, and unresponsiveness. These are the signs symptoms, and along with these, tachycardia, reduced urine output, tachypnea, hypotension, and reduced pulse pressure. These are the signs of hypovolemic shock, means decreased blood in the body. And the management of this condition will be obstetric hemorrhage protocol, primary survey, airway, breathe, circulation. Drugs should be given. Stop uterine bleeding by massaging uterus, bimanual compression, recover any clot, remove clot from the uterus and the vagina. Uterotonic agents include oxytocin, misoprostol, and centrometrine and ergotamine with carbapenem drugs. These are the drugs should be given in order to prevent the bleeding. Uterotonic agent. These are also known as uterotonic agent. So the another disease of uterine rupture and inversion is uh, uterine rupture. Uterine rupture occurs in the labor, and risk factors are the previous uterine scar from C-section with congenital abnormality of the uterus, use of oxytocin in the labor, and failure to recognize obstetric labor. Signs and symptoms are the sudden onset abdominal pain with fetal part, with resection of the presenting fetal part, fetal distress, and vaginal bleeding in maternal shock. So these are the signs symptoms. Management of the condition is maternal resuscitation, urgent lower segment C-section, vaginal delivery should be done, and if cervix is dilated, followed by laparotomy to repair the uterine rupture. There are four stages of uterine inversion. Sorry. So for first stage, this is degree 1, and this is second degree, and in third degree, and in fourth stage, total outlet of the uterus has taken place. So in this way, the risk factor are full dilated C-section, malpresentation, prolonged secondary stage, abnormal adhesion of the placenta, short cord, previous uterine inversion, strong traction of the umbilical cord with excessive fundal part, and inconsistent evidence of the support this condition. Management will be called for help. Obstetric hemorrhage protocol should be treated, and the relax the patient by stop uterotonic agent. Consider tocolytic agents, hydrostatic repositioning, surgical procedure like most important hysterectomy should be done in this condition. So in this way, this condition is managed.